We call upon the next speaker, Dr. Anju. She is a consultant oculoplastic surgeon at Comtrust High Hospital. Over to you, Anju. She is a specialist.
Thank you all. Thank you, ma'am, for this opportunity. Good morning to all of you. So it isn't rare to see a patient like this in our OPD with typical features of thyroid eye disease. Okay, we can identify them, but what next? So the purpose of the talk today is to help identify, grade, and outline the management for this patient. So we'll quickly go through the disease as such. It is the main extrathyroidal manifestation of Graves' disease. It is an autoimmune disorder which is characterized by enlargement of the orbital fat and extraocular muscles. It is as a result of thyroid dysfunction, majorly contributed by hyperthyroidism, that is around 90%, and the remaining 10% is equally distributed between hypothyroids and euthyroids. It manifests more commonly in females in the age group between 30 to 50 years, but greater severity is noted in elderly, especially males. And smoking has been known to be a risk factor which increases the severity as well as gives a poorer outcome in such patients by 7.7 times and a greater predisposition to Caucasians. In brief about the pathogenesis so that it will help us understand the management better. So antibodies are directed against the thyrotropin receptors on the thyroid gland. Similarly, receptors are present on the orbital fat cells as well. And antibodies stimulate an inflammatory cascade leading to an increase of adipogenesis, leading to enlarged extraocular muscles and fat expansion and inflammation. So this is the Rundle's curve. It helps stage the activity of the disease. The initial is the active or the progressive stage, where it usually lasts between 6 to 18 months. And during this time, if we initiate any medical treatment or radiotherapy, it will limit the complications later. This is followed by a stable or quiescent or inactive phase, during which most of the rehabilitative surgeries are done. Having said about activity, another term that's commonly used is the severity, which documents the pattern and the extent of the disease. So thyroid has numerous named signs. If we go into this, we can take the entire day. So I'll be skipping this slide. Grading of thyroid has been, thyroid eye disease has evolved over the years. Initially, it began with the no specs classification, which classified both signs as well as symptoms under one. So which is why we had to abandon it later, because it failed to grade the severity and did not assess the disease progression. Later in 1999, the European group on Graves' orbitopathy came up with a UGOGO severity scale, which classified the disease into mild, moderate to severe, and sight-threatening. Sight-threatening including the dysthyroid optic neuropathy and corneal ulceration. Later, Moritz et al. Described the CAS, that is the clinical activity score, which is a binary scale with scores based on the presence or absence of soft tissue inflammation. And in the initial visit, there are 7 criteria that need to, and 3 out of 7 meant an active disease. On a follow-up visit, an additional 3 parameters were included and 4 out of 10 is considered active. Then came the VISA classification by the International Thyroid Eye Disease Study. So this documents the 4 parameters based on vision, inflammation, strabismus, and appearance. And this records both subjective as well as the objective measurements and helps grade the activity as well as the severity, and also documents the progression of the disease. Now coming to the investigations, we know that we have to routinely send for a thyroid function test. Most of these patients will be evaluated and under the follow-up of endocrinologists as well. The ocular investigations that we need to do is vision, color vision, extraocular muscles movement, IOP, visual fields, diplopia charting, and in case of dysthyroid optic neuropathy, we need to do a VEP and fundus photo for documentation. So initially the imaging used to be ultrasound of the orbits, but since it gave lesser details, now we have shifted to CT orbits as well as MRI. In CT orbits, you can classically see that there is an enlargement of the fat volume behind the orbit, and similarly the classical enlargement of the extraocular muscles sparing the tendon. If you look at the coronal sections, you can make out if there is any apical crowding, that is the enlargement of extraocular muscles can lead to an optic nerve compromise, and this is helped by the Barrett's index. MRI is not done routinely. It is indicated in cases of unilateral or strongly asymmetric exophthalmos or suspected dysthyroid optic neuropathy, or in patients who have the clinical features but are euthyroid with normal thyroid serology. It also gives us an idea about the radiological activity of the disease. Management is based on the stage of the disease and the activity and severity, and our goal is to preserve vision as well as reduce complications. So mild or inactive disease includes home vision monitoring, behavioral modification, most of which, most important is stopping smoking, and the patient can be put on oral antioxidants, that is selenium, 100 microgram twice daily for 6 months. It is said to reduce the progress of the disease. Coming to the moderate or severe disease, recently the Yoga guidelines that came in 2021 came up with this guidelines that intravenous corticosteroids with or without mycophenolate mofetil can be started as a first line, and this is usually given as weekly dosages, and it begins with 500 milligrams weekly for 6 weeks, followed by 250 milligram weekly for 6 weeks, and a maximum dosage should not be more than 8 grams to prevent further complications, systemic side effects. So in patients who do not respond to steroids or who are known diabetics, other modalities are use of azathioprine, methotrexate, cyclophosphamide and cyclosporin. Coming to dysthyroid optic neuropathy, the first line of therapy for this is also glucocorticoids, that is IVMP. Here we follow a pulse therapy of giving IVMP for 3 days, following which we look for the outcome. If there is no improvement, then the patient has to undergo an urgent surgical decompression. Radiotherapy is a lesser known modality of treatment, but it can be given as concurrent treatment along with intravenous steroids, and is said to give a good outcome. Surgical management, I will just be briefly talking about this because each part needs to be dealt with in a separate session, ideally. So in an active disease, like I said earlier, if there is sight-threatening dawn, or if there is no response to medical management, or there is severe progressive active disease with gross proptosis or exposure keratopathy, the patient needs to undergo an orbital decompression. Based on the severity, it can be 1 wall, 2 wall or 3 wall along with fat decompression. The order that we follow in a quiescent disease is first decompression, followed by strabismus surgery, and finally lid surgeries. So our favorite new kid on the block is teprotumab. Studies have proven that it not only reduces the activity of the disease but also improves the proptosis. But unfortunately, it is still not available in India. It is rampantly used in USA. The other drugs are rituximab, tocilizumab, sirolimus, and ongoing trials in belimumab. These need to be given in a setup where the patient can be monitored for systemic adverse effects. So what is new? Non-surgical techniques of correcting lid retraction have come, where injection of triamcinolone acetate can be given either subconjunctivally or transcutaneously. And the use of hyaluronic acid gel fillers will also help correct retraction to an extent. And the use of injection botulinum as well, which is usually given subconjunctivally or transcutaneously. So to briefly sum up the management, active TED, once diagnosed, we stage it into mild, moderate to severe or severe. If it is mild, like we said, the conservative management where we observe the patient. If it is moderate to severe, IVMP pulse therapy where 500 milligram IV is given weekly for 6 weeks, then we look for a good response. If yes, then 250 milligrams for 6 weeks with or without radiotherapy, and then you observe the patient. If it's a suboptimal response, then you can either change to immunomodulators along with radiotherapy, and you need to maintain the immunosuppressants for a while, and eventually the patient may require a sequential surgery. And like we said, enough emphasis cannot be laid on dysthyroid optic neuropathy, for often it may be missed. So in such cases, we need to identify correctly, give high dose IV MPs, and the rest of the management as we discussed earlier. 6 minutes was a very short time to talk about the entire of thyroid eye disease. Anyway, thank you for the opportunity.
Thank you, Dr. Anju. That was a wonderful presentation. And this is an underdiagnosed condition, in fact. And the management also, so many gray areas, I mean, among the general ophthalmologists. Thank you for clearing these, throwing light on this